Chloroform turned a butcher's shop into a surgical theatre, a chemical trick that let surgeons silence pain and actually do careful work where once only speed and brute force stood a chance. Welcome back. I'm the Archive. I've been reading the field hospital reports for decades. Today, we're about the business of that Civil War medical breakthrough. How a simple anesthetic routine reshaped battlefield surgery, what it actually did to the brain, and why chloroform edged out ether on the firing line. Before reliable general anesthesia, battlefield surgery was an ordeal of one brutal metric. How fast could you saw a limb away while the man screamed? Patients were held down by attendants. Some were dosed with spirits. Most were simply expected to endure. That setup limited surgeons to the most obvious life or limb interventions: amputations, bullet extractions, and furious trimming of shattered tissue. Speed was the weapon. Precision was impossible. This wasn't just a moral problem. It was tactical. The shock of pain could kill a wounded man before his wound did. Hasty surgery increased bleeding and left surgeons unable to clean wounds properly, which raised infection rates. The battlefield needed a method that was fast, portable, robust, and simple enough to work by candlelight in a tent. It needed to turn a screaming casualty into a still patient within minutes, so the surgeon could ligate vessels, clean tissue, and close wounds with care. That was the practical itch Civil War medicine scratched. The chemicals existed already. Ether had been demonstrated in 1846, but the war demanded a solution that worked in the field. Ether is effective, but it's highly flammable and slower to act. Chloroform, introduced earlier in anesthesia history and rapidly adopted by many military surgeons, wasn't perfect, but it fit the battlefield's constraints. It acted faster, was not flammable near lanterns and open flames, and required smaller quantities per dose. The common implementation was as simple as it gets: a rag or a Schimmelbusch mask with a few drops of chloroform held over the nose and mouth until the patient lost consciousness. Administered with discipline, it rendered a man insensible in under 2 minutes and allowed surgeons to operate with an unprecedented degree of calm and thoroughness. That chloroform rag is what turned chaotic butcher shop amputations into surgical procedures that could aim for survival instead of mere speed. At a practical level, chloroform's effect was immediate. Inhaled vapor entered the lungs, passed into the bloodstream, and then crossed the blood-brain barrier. Chloroform is lipophilic. It dissolves into fatty cell membranes, and that property is the key. Once in the brain's lipid-rich environment, chloroform physically alters neuronal membranes and interferes with ion channel function. Neurons communicate by controlled flows of ions. Anesthetics blunt those flows. Rather than targeting a single receptor like a lock and key, chloroform causes a generalized blunting of neuronal excitability. Think of it as muffling the brain's chatter. Higher cortical circuits that produce awareness and pain perception are very sensitive to this disruption. The brainstem, centers that control basic life functions, are more robust, but they can be pushed too far. The goal is a narrow window. Cut cortical signaling enough to stop pain and awareness without crippling breathing or cardiac control. That biochemical action is the exact neural mechanism in working terms. Lipid solubility permits penetration into the brain, which then alters membrane properties and the function of ion channels, thereby disrupting the coordinated electrical activity necessary for conscious sensation. Ether works, but it's a pain in the field. It's highly flammable, a killer risk when your tent has open flame for light and heat. Ether's onset can be slower, and it commonly caused violent retching that contaminated the surgical field. Chloroform, by contrast, acts more quickly and smoothly. The dose per operation is smaller, the bottle is compact, and there's no immediate fire hazard. Logistics matter in war. Lighter load, lower fire risk, faster induction, and fewer vomit interruptions. That's why many surgeons preferred chloroform despite its delayed toxicity. Put bluntly, chloroform was the no-nonsense choice for a frontline tent. It wasn't safe in the long run, and it carried its own lethal risks, but it let surgeons stop the screaming and do better work. Administration was standardized by necessity. A cloth or mask soaked with a few drops of chloroform was placed over the nose and mouth. An assistant added drops at intervals while watching breathing and pulse. Surgeons learned the stages: initial excitement and coughing, a delirious phase, then the surgical stage. Slow, regular respirations, flaccid limbs, loss of reflexes. The anesthetist's task was to keep the patient in that surgical window. No movement, no pain response, but spontaneous respiration intact. This discipline created the first informal anesthetist role on the battlefield. Someone dedicated to monitoring pulse, breathing depth, and skin color, and adjusting dosage accordingly. It was primitive compared to modern anesthesia, but it introduced a crucial operational model. Anesthesia requires continuous attention, not an once-and-forget pour. Anesthesia bought time. Where a surgeon used to be measured by how few seconds an amputation took, they now had minutes to be methodical. Ligatures could be placed properly, devitalized tissue could be excised, hemorrhage could be controlled. That reduced mortality from immediate hemorrhage and gave wounded men better odds of surviving the post-operative period. It also changed the psychology of surgery. A motionless, insensible patient made it possible for surgeons to perform more complex repairs and to attempt procedures previously impossible under the yoke of pain. The field hospital became, in crude form, a surgical theatre. That shift set the stage for later antiseptic and aseptic developments. Once surgeons could take time, cleanliness became not just humane, but useful. Chloroform was not a free pass. It had three main problems. 1. Narrow therapeutic window. Too little, and the patient felt pain. Too much, and respiration and cardiac function could depress to fatal levels. Overdose could kill instantly. 2. Delayed organ toxicity. Chloroform could cause liver damage and delayed fatal outcomes in days following a procedure. That brutal fact meant some patients survived the knife only to die later of hepatic failure. 3. False confidence. Anesthesia encouraged more complex, longer operations in filth. Surgeons still worked in blood-soaked coats, reused instruments, and rarely scrubbed. More thorough surgery in those conditions increased post-operative infections. Anesthesia exposed the next big problem: sepsis, in glaring relief. In short, chloroform solved the immediate agony and tactical limits, but it also shifted the battlefield's mortality curve toward infection and organ complications. The procedure was a step forward, but it revealed a deeper medical gap, antisepsis, that would take decades more to close. Because anesthesia required monitoring, field hospitals evolved roles and routines. The anesthetist as a care role began to appear, an assistant watching a patient's pulse and breathing while the surgeon worked. Packing for supplies changed. Anesthetics became standard kit items when available. Training shifted. Surgeons needed to be competent not only with scalpels, but also with dosing and watching for anesthetic complications. Where chloroform bottles were scarce, for instance, in the Confederate South under blockade, surgeries sometimes went forward without anesthesia or with substitutes. That disparity had a direct human cost. Some theatres of war saw more excruciating surgeries because supply lines failed. The medical supply chain, in that sense, became a front of the war itself. The Civil War's anesthesia story is the textbook case of a technology being systematized under pressure. Chloroform normalized the idea that rendering a patient insensible is a prerequisite for humane, effective surgery. That normalization created demand for better techniques and safer agents, and it forced medicine to confront infection control. In other words, anesthesia didn't solve everything, but it made the next advances possible. Once pain was no longer the limiting constraint, surgeons pushed for cleaner technique, sterilization, and later germ theory acceptance. The modern operating room, with an anesthetist, sterile gowning, ligatures, and careful tissue handling, is the historical descendant of that field tent moment when a rag and a bottle bought minutes of surgical grace. On the ground, the routine was ugly and simple. An assistant would hold a dampened cloth to the nose and mouth, while other hands restrained the soldier. The patient's eyes rolled, the breathing slowed, muscles relaxed. The surgeon felt the relief. The room quieted from screams to steady, grim concentration. But the team never relaxed. The anaesthetist watched the chest rise, felt the pulse, and signaled tiny adjustments. One misplaced drop, one distracted eye, and the patient could lose respiration. That tension is what forged the habit of monitoring and the eventual professionalization of the role. In many ways, Civil War anesthesia is also a lesson in human systems. The technology that saves lives only works when coupled to disciplined process, supply reliability, and trained people. The 90-second chloroform procedure was a pivotal, no-nonsense advance. It turned frenetic amputation into deliberate surgery, reduced immediate mortality from shock and hemorrhage, and created the conditions that made antisepsis and modern surgical technique inevitable. It also taught a harsher lesson. A medical fix rarely ends the problem. It moves the frontier of failure. Chloroform made surgery possible on the battlefield, and then made infection more visible and more urgent to fix. If you remember anything from this lesson, remember this simple old man truth. Technology buys you time, but discipline and follow-through determine whether that time saves a life. The rag and bottle were triumphs of necessity. They taught surgeons to take the extra minute to do the job right, when they could, and that makes all the difference.